All right, I'm Dr. Ebonie Vincent, and I'm here with Dr. Christopher Bromley, and he is from Poughkeepsie, New York, and we're here discussing tendinitis, tendinosis, plantar plate repairs. So he's going to give us some nuts and bolts on information about those things. So Dr. Bromley, please tell me where you practice and what kind of pathologies that you're mostly seeing.
Great. I'm in Poughkeepsie, as you mentioned. It's an hour north of New York City, lovely area. I have a sports medicine and surgery practice. A few other doctors that work with me do pretty much everything that a podiatrist would do. My unique interest is in the sports side and rehabilitation. I work with a lot of athletes, young and old. And we're focusing this weekend on some of the tendinitis, tendinosis discussion, and then also another presentation on plantar plate repair.
Nice. So let's start with discussing tendinitis, because I think that's a lot of patients come in with tendinitis. Can you walk us through your conservative care options and then kind of lead us into when that patient needs surgery?
Well, I think that's a great question. The big thing is the evaluation. So we're going to get a great history, and ultrasound is my favorite. I have an ultrasound machine that follows me around all day.
Nice.
And I think that's really important because we can show the patient where the defect is, if they have a tear in the tendon, or if it's just a tendinitis where the peritoneum is swollen. So I think that's really key, understanding that, and then show the patient that, get them to buy in and educate them in reference to where we're going to go.
Right, that's really interesting. So you use your ultrasound as the key diagnostic tool as opposed to an MRI?
Yes,
that's
because
really
it's
great.
instantly available.
Yeah.
You know, and for many years, all I had was X-ray in my fingers.
Right.
And a history. So being able to use the ultrasound to show the patient exactly where the pathology is, and all the patients have their cell phones.
Right.
So I make them take a
picture.
Right, take a picture.
That's perfect.
Take this home. Show your husband or your wife.
Exactly.
And then we talk about where we're going to go. So if it's an acute tendinitis or acute tendon injury, typically in my practice, we're going to use kinesio tape. We're going to use lots of education, range of motion, strengthening, activity modification. I tend to stay away from anti-inflammatory medications, and I'm not a fan of cortisone. Both of the oral NSAIDs and cortisone injections tend to suppress your immune system, suppress the body's ability to heal itself. Inflammation is the first phase of healing.
Right.
So we want to kind of avoid that. And then if you have a patient with a more chronic injury, you know, where there's a lesion or the collagen formations have failed and the structure is blown out, those would become a little bit more aggressive with those. So with those patients, they may be candidate for shockwave, which I like very much. I don't like having to do it myself, but I like if somebody else does it.
Yes.
And then in our practice, we use a lot of biologics, and so the amnion injections, where it used to be micronized, now we have amniotic fluid. It's shelf stable.
And that's also ultrasound guided that you do? Okay, that's perfect.
So we offer that to patients, very reasonable costs to them, and we give them that as a first option.
I like that. I like that a lot. So describe to me when you would deem it necessary to take a patient to surgery, and then if in surgery, what products do you use, or how would you kickstart that healing process if you had to take a patient to surgery?
That's a great question. So the magic window for me is 6 months. If someone has had, we've done all the conservative things and they've been compliant, we got 6 months in and they have pain. One of the key diagnostic tools we also use is a high frequency ultrasound where we're looking at color. When you look at an ultrasound and you've got a tendon injury where you're going to see a lot of blood flow in the tendon where you don't normally see it, those are the patients we've got loss of structure. We're going to take those patients to the operating room. And there are two different techniques I use. The workshop we gave today was for 10X. So we'll use 10X percutaneous minimally invasive surgery for that. And I may or may not pair that with a biologic. So we'll go ahead and do the debridement. And maybe it's a distal Achilles insertion or plantar fascia, or posterior tibial. And then when I'm done, I'll put a little stitch in the hole, and then I'll backfill ultrasound guided the biologics into that injury, and we get super great results, very fast, very happy patients. That's really the key to minimally invasive. Now, the open cases where we can't resolve it percutaneously, those the same thing. We'll go in and do good meticulous debridement. I've seen your surgery, you're a great surgeon, and then I usually will pair a biologic with that as well. So if we have a tendon, we'll use a biologic underneath, wrap it around, and give the patient an opportunity to use those special materials to reduce inflammation, fight off scar tissue, and reduce pain, and get them back to activity very quickly.
So would you suggest that all patients try the more minimally invasive procedure at first, or would you demarcate those who would benefit well from the percutaneous versus open procedure?
Good question. I think that we really try to lean on the percutaneous side, and I've been doing 10X since 2011. So in the beginning, the percutaneous procedure, it took a while for me to get the hang of it. There's sort of an art to the hand-eye, so you're doing the ultrasound at the same time you're doing it, and to be honest, it took me a while to get good at it. And any of the ones I ever had to redo are the ones I did at the beginning.
Right.
So I think that doing that is really helpful. It's really minimized the amount of times I actually have to do an open case.
Right.
And if you look at the literature, if you take Achilles tendon rupture, if you look at the literature says that even if you have a full tendon rupture, it may be better not to go in and not to do an open repair, because the open repair techniques that we have are so invasive, and there's complications are very high, and we're putting a foreign body, with these very elaborate suture repairs, right? We're really, sometimes we're doing more harm than we are good,
right?
Because we're drilling holes, and we're just, I don't think we're doing our patients a service.
Right.
So if we can do it percutaneously and we can avoid open surgery, that's really my philosophy.
Absolutely. The only other question I have, because I'm curious, a lot of times in my practice, especially, people want a repeat MRI after they're healed. I'm like, does it hurt? No. So there's no reason for you to MRI. But with your ultrasound technique, do you do repeat ultrasound to show people this was your torn tendon before and now it's healed?
Yeah, great. Yeah. Great, that's an awesome question. So what we typically do with ultrasound, for example, you have a hypoechoic area. That's the area that's damaged. If you have a good ultrasound, you can actually map that out, take a picture, it'll be saved in your archive. So then we go back and see the patient 3 months post 10X. Okay. We can actually measure the area and quantitatively not only show them the image, but actually show them the measurement. The tendons decrease in thickness, and we can see the decrease in the hypoechoic area, which makes them feel really good about their results.
I actually really love that. That's pretty great.
Yeah, tricks of the trade.
Yeah. Well, thank you so much. This has been great. Is there any other pearls of wisdom that you would like to share with me, so that way we can all learn exactly from you?
I think the other topic we're really focused on tomorrow is that sort of plantar plate injury.
Yes. Talk about that.
And I think that's really the key to that too is ultrasound on the diagnostic side. So good history, looking at the ultrasound so you can see the defect. And dirty little secret, I hate plantar plate repairs. They're not. You and everyone else. Right. They're really not that fun to do and not that rewarding because they don't work.
Right.
So a couple of pearls. One is intraoperatively. I was trained, and I hate to admit this, but I've been out almost 30 years. And when I finished school, the McGlamory elevator was really popular. Right. Really popular. Everybody loved McGlamory. They still do. I'm not a fan of the McGlamory elevator because I think when you perform that, if you didn't have a plantar plate defect, right? you have one now, right? Because you just de-articulated the proximal attachment. Right. So I don't use those at all, and I recommend when I give the lecture that they don't. When we're looking at plantar plate options, Lately, I've become a big fan of the new Paragon toe tack. Okay. So basically, the philosophy is you're going to make a plantar approach, base of the phalanx, guide wire through, and then you're drilling a 2.8 hole, and a two-piece implant goes in, and you hold the toe in the corrected position. So you're using the plantar, the long and short flexor tendon complex, to hold that toe in place. And take over for what the
plantar plate was supposed to do.
Right. I see. And you don't have to do an osteotomy in the mat. You don't have to open up and create a lot of dorsal scarring because we know every time we cut into an MTP, dorsally, you end up with a worse injury than you had because of the
Exactly.
contracture,
Right.
because of what happens to the extensor hood. So I think doing this plantar plate substitute with the flexor compression with the toe tack has been my new sort of
That's been your
favorite.
new thing.
Yeah,
The patients have a good outcome?
they
Like,
do,
okay.
because you can get some medial lateral correction and hold the toe down. The only pearl that you have to watch is in women with smaller bone structure,
Yeah.
if they have a small, very small proximal phalanx, you have to kind of keep in mind that the implant is a 2.8, and a 2.8 and a very small bone may be too much. So we've been playing around in our operating room with using some soft tissue anchors. So basically just take an anchor, drill it into the bottom, and I tie the anchor down with the toe in the correct position without having to use a very complicated
Wow, that
implant.
is very interesting. How soon can people resume normal activity or ambulate normally after something like that?
Well, I think that we're going to rebalance that whole joint. So I'm typically a little bit more conservative. I mean, I'll walk my sort of bunion patients right away in a CAN boot, and most of my 4-foot osteotomy bunion cases are in a soft shoe at 3.5 to 4 weeks.
Okay.
These particular patients, I take a little bit longer. So they'll be in a boot up to 6 weeks, and then I tell them they'll spend 6 weeks in a stiffer shoe. I make them go out and buy, if it's wintertime, like
Right.
a hiking boot,
Okay.
or in the summertime, I'm a big fan of Hoka, H-O-K-A,
Oh, yeah,
their shoes.
I like
Because
Hoka
they
too.
don't,
It has, like, little-
yeah, they also make me taller.
Oh.
So we use the Hoka shoe because it has a very stiff forefoot,
Right.
and that'll be from week 6 out to week 12.
Wow.
They do take a longer time to heal, but you don't have to do any of that dorsal dissection. So that's really been my success.
Well, that's good, because anytime you're dealing with a joint capsule, it's like scary territory. You know, what is your philosophy of the Wael? Just because I have you here.
I know Dr. Wael, senior and junior, very well.
Okay.
Great friends of mine. I use the Wael as part of my practice for many years, and I like it. It's well done. The downside of the Wael is we are making that extensor hood. We're violating the dorsal part of the capsule, which just automatically leads to contracture. But when indicated, I don't think it's a substitution for doing that plantar repair that we're doing with the
Right.
anchors and the toe tack. But I do think if you do have an elongated met, or you've had an iatrogenically short first ray and you've
Right.
got to shorten
Pull
the
back,
second
right.
to
Viable
accommodate.
option.
Right. So
Excellent.
I think when indicated, it works really well. And sort of my go-to for fixation there was 1 or 2 snap-off screws.
Well, wonderful.
Yeah.
I like it. You have the minimally invasive ways, you have your open surgery ways, and then you just have to be smart about which type of procedure you're doing for each patient.
Right patient, right procedure.
Right. And I like that you have options.
Right.
And that's amazing. So thank you so much for everything. And again, we are here at the Indigo Hotel in Los Angeles at Prison E-Learning Systems Conference. This has been great. And thank you so much.
Awesome.
Okay.